of information and help for the young lot coming ahead.
Yes, the honor is ours. Thanks.
So I think we should start the lecture. The topic
Yes, go ahead.
today, which I'm going to discuss, is rheumatogenic retinal detachment. And I have tried to simplify this topic as much as I could possibly do because it covers a lot of areas. It is a huge thing, but I have tried my best to make it very simple for the young residents and fellows uh, who are attending this topic. So, first of all, I just would like to simply tell what is rheumatogenic retinal detachment. Consider a room and there is a wallpaper which is being attached on the walls of that particular room. Somehow, if there is a break or a tear in the wallpaper, the rest of the wallpaper will also start erode off. And a day will come, whole of the wallpaper will be gone. So there are three things very important to understand in rheumatogenic retinal detachment. The first one is the retina itself, which is attached underside with retinal pigment epithelium and from its inside with the vitreous and from its outside with the retinal pigment epithelium. These three structures are very important for the rheumatogenic retinal detachment to be completely understood and to follow the course of the disease and the treatment. If I grossly go into the types of retinal detachment, there are three types of retinal detachment. First one is the rheumatogenic retinal detachment, as the name is indicating there is a rhegma, break in the retina, which causes the fluid from the vitreous to push into that break, and it separates the neurosensory retina from the retinal pigment epithelium. The next one is the exudative retinal detachment, which is more common in tumors, inflammations, and other inflammatory conditions. Third one is the tractional retinal detachment, in which the retina is pulled off by some structure like a proliferative vitreous retinopathy or a fibrovascular proliferations in diabetes, trauma, or a foreign body. So, for my junior colleagues, what is RRD? RRD, it is a rhegma break which is created in the neurosensory retina. As a result, the fluid which is in the vitreous, it seeps through that break and separates the neurosensory retina from the pigment epithelium. And once that chain reaction starts, it keeps on going till whole of the retina it gets detached. And once the retina gets detached, the photoreceptors which are present in the neurosensory retina, they get uh, anoxic, they get degenerated as a result of less supply of nutrients to those particular photoreceptors. So you can take the screenshot of this particular slide, which is very helpful. Here I have elaborated few steps. First one, which is the vitreous. If we talk about the normal aging process, what happens with age, the vitreous, it becomes fluid-like, which is called as syneresis of the vitreous. And once the vitreous starts becoming a fluid or syneretic, it starts detaching itself from the particular points on the retina. Still, there are very strong adhesions present with the vitreous and the retina from where it doesn't detach. As a result, more force or more powerful attraction is required to detach the vitreous from that particular point. As a result, when a comes into play, or when some counter coup movements come into play, the retinal break is created. So that is the catastrophe beginning point. Once the retinal break is created, the fluid which is already present in the vitreous, it starts seeping through that particular break and it starts detaching the neurosensory part of the retina from the retinal pigment epithelium. It is not only detaching, it also causes the photoreceptors to get denatured, to get uh, anoxic, completely anoxic. It's not only the vitreous fluid which goes from the neurosensory retina under the neurosensory retina and separates the RPE and NSR. It is another catastrophe which is happening is that the retinal pigment epithelium, it also starts migrating from the RPE through that break into the vitreous area, and it spreads over the surface of the retina. This is the diagrammatic presentation, and this is what I was talking. When the retinal pigment epithelium, it starts migrating from that particular hole into the vitreous, it spreads over the interior surface of the retina. So where it transforms its nature. Normally, the retinal pigment epithelium cells, they are columnar based. And the sole responsibility of RPE cells is to provide nourishment to the retina and also to remove the waste materials from the NSR through the choriocapillaries. So once the RPE cells, they migrate into the vitreous and spreads over the surface of the retina, they change its form. They transforms into another cell type, which is fibrotic. And the fibrous component has a tendency to contract. Here you can see in this picture the wrinkles getting formed over the surface of the retina. So this is the biggest catastrophe in rhegmatogenous retinal detachment. If the rhegmatogenous retinal detachment, if it is all about simply a break and the separation of NSR, RPE, things are very easy for the retinal surgeon. But when the PVR, the proliferative vitreoretinopathy, when it comes into play, things become very difficult, very challenging for the retinal specialist, and also the prognosis of that particular eye or the retina, it starts decreasing. So for the young ophthalmologists and fellows, it's very important to remember the definition of this PVR and the mechanism of formation of this PVR. Here I have taken few of the diagrams courtesy to my resident Ahmed Fozan, who really helped me taking those photographs. You can see in the center one, there, there is a you can see in the center picture, there is a tobacco dusting, which is seen right behind the posterior capsule. This is the first thing which will a retinal surgeon will notice in this rhegmatogenous retinal detachment. And this is also called as PVRA, when there is just the break formation. No big retinal detachment is present. The only thing which will be noticed is this Schaeffer sign, that is the retinal pigment epithelium cells in the anterior vitreous phase, the break, which will be having a cuff of fluid around it, or which could be larger than 1 disc diameter. If the cuff of fluid becomes larger than 1 disc diameter, this is by definition rhegmatogenous retinal detachment. And if it remains less than 1 disc diameter, it is called as subclinical rhegmatogenous retinal detachment. And a retinal surgeon and the patient is very lucky if that patient presents at this particular stage. Because if the break is there, we can simply apply the laser, which you can see in this third picture. The laser is being applied around the break, and most of the retina is salvaged or the VN is saved. So let me show you the small video of this Schaeffer or this vitreous RPE clumps in the vitreous. Now this is the second diagram, and the second stage of proliferative vitreoretinopathy, which is called as PVRB. Here you can see the wrinkles on the retinal surface, just like a wave being formed over the surface of the sea. The wrinkle formation and the folding of the edges of the retina. This is the this is the classical sign, or this is the classical picture of proliferative retinopathy B. Now, this is the proliferative retinopathy stage C. You for my juniors, it is very important to remember only these three stages: A, B, C, not more than that. D, E, F, G, A. This is the R clock representation of PVRC. You need only to remember three stages of PVR, that is A, B, and C. In stage C, you can see the star folds, the folds on the retina. It starts becoming very much evident. Retina becomes very much stiff because the fibrosis is not only being formed at the anterior surface of the retina, it is also formed within the retina and also under the retina. You can see in the second and third picture, the PVR folds are quite evident, and it is making the retina stiff, and the folds start appearing on the surface of the retina. This is the representation PVR A, B, and C. You can see the things happening. If you talk about the PVR A, cells just enter the battlefield, means this tobacco dust, Schaeffer sign. If you talk about the PVR B, the retina becomes tight and the surface starts having corrugations over it. If you talk about the C, the movement of the retina, it becomes less. Retina is getting stiff and star folds start appearing on the surface of the retina. Now, what is macula on and macula off? Well, if I sequentially tell you, um, this is the third most important thing in rhegmatogenous retinal detachment, which one has to remember. If you see the retinal picture, the arcades, it's actually marking the boundary of the macula. Any rhegmatogenous retinal detachment which has entered the arcade or touched the arcade actually has partially or completely involved the retina. And you can see it on optical coherence tomography for better knowing and better visualization. So the third most important thing after posterior vitreous detachment, after the PVR, which PVR is present, the third most important thing which you have to talk about the rhegmatogenous retinal detachment is the status of the macula. Whether the macula is on, the patient would be having a very good VN, but he or she would be saying that there is a curtain-like effect coming in front of my eye. I can see something coming from my peripheral visual field in front of my eye. And if the macula is getting off, or surely we are losing the most viable VN of the patient, and then the battle with the time starts. So this is the clinical presentation of how the patient comes to us, and what are the symptoms he or she comes with, and then what are the signs which actually are evident. Most important symptom with which the patient would present to you is floaters, flashes, and curtain-like effect. If the detachment goes on, the patient would complain that there is a shower of cells in front of me. The VN is blurred, but there is a huge number of things floating in front of my VN. And some intelligent patients would always say that there is something coming in front of my field of view. So these are the signs and symptoms I have summarized. And if I briefly summarize what we have done up till now for my residents and for my fellows, I would always say that if you have to describe the rhegmatogenous retinal detachment, it is with the five things. Five things you must know when you are describing a case of rhegmatogenous retinal detachment. The first one is whether the posterior vitreous detachment is present or not. Second one is the R clock presentation of the retinal detachment. Say you are not supposed to say this is a partial retinal detachment, this is a complete retinal detachment, this is inferior or a superior retinal. You have to say this is a retinal detachment, rhegmatogenous retinal detachment from 10 to 4 o'clock, from 3 to 9 o'clock, from 9 to 2 o'clock. You getting my point? The second most important thing is the R clock representation of the rhegmatogenous retinal detachment. Third one, you have to tell about the status of the macula. whether the macula is on or off. Fourth, the PVR status. It's PVR A, it's PVR B, or PVR C. If that PVR C, the star folds, sorry, if the PVRC is there and the star folds are involving the posterior part of the retina, this is called as PVRCP. And if those star folds have come along the retinal vessels towards the ora serrata involving the anterior part, it is called as PVRCA. This is all you guys must know about the PVR. Nothing more than that. And the fifth most important thing is the position of the retina. Initially, fresh detachments always follow the Linkoff's rule.
Hello? I think there is an internet connection issues. Dr. Hassanin?
So, can you hear me?
Yes, I think you're
Let me share the screen again.
all right.
So, can you see that?
Yes, it's clear.
It's clear. Yeah. So now the treatment goal is that we have to close that culprit break. We have to relieve the traction around that break, and we have to go for the reattachment procedure. So here are some of the techniques through which we can do we can repair the ligamentogenous retinal detachment. The initial techniques involves the cryotherapy or the external implants like scleral buckling. The recent or the most up-to-date techniques of the treating rheumatogenic retinal detachment is the pneumatic retinopexy. Pneumatic retinopexy is particularly for those rheumatogenic retinal detachments which are above the horizontal raphe, that is from 9 to 3 o'clock position, usually one or two breaks in the same plane. And for that pneumatic retinopexy, macula has to be on or partially detached. You can do retinopexy, pneumatic retinopexy in completely macula of detachments, but for fruitable results, but for better results, macula should be on in those cases. Scleral buckling is now getting outdated. It involves an external exoplant with which we indent externally and approximate the RPE to NSR. Again, the most up-to-date procedure which is being done, mostly it is the pars plana vitrectomy, which is 23 gauge, 25 gauge, 27 gauge, 3-port, 4-port, 5-port, depending on your ease. You go in, you do the vitrectomy, you clear the break of the vitreous attachments, then do the air fluid exchange, which I'll show you later, and then put in the endotamponade. You can take the picture of these principles of treatment. I have summarized these principles for the residents and the young fellows. Now, this is the most important thing. All residents and fellows must remember this table. This is the silicone oil which are being used as an endotamponade, the viscosity of those oil, and the specific gravity in which those oils are available. Most
There must be a technical issue.